And I will go now to our next speaker, Heather Whitson from Duke University Medical Center. She will talk about improving the evidence base for ADRD patients with multiple comorbid conditions and impairments. So Heather, please go ahead.
Hello, can you hear me okay?
Yes,
yes, we do.
All right. So I'm going to be talking today about comorbidity-based disparities in Alzheimer's disease, and in particular, how we can improve the evidence base for addressing this type of disparity. And sort of an overarching premise of this talk is that this is really a two-way street. So cognitive health affects the course of many other diseases. And likewise, medical comorbidity affects cognitive health. So I'm going to start with sort of the first direction on that street. And for those of you who study a particular comorbidity, say diabetes or cancer, or a particular type of procedure like surgery, cognitive impairment is likely a risk factor for the disease-specific outcomes or complications related to that comorbidity. This is just one example. So this is a study that looked at 720 people who were hospitalized for heart failure and found that the mini-cog test, which was administered on the day of admission, was highly predictive for this outcome of hospital readmission risk. And what was noted by the authors, this was a somewhat surprising find, how predictive this one single cognitive test was. And what they noted was that sort of because it's such an easy and quick test, regardless of why it's so predictive of readmission risk, it's a helpful thing to know and could be a useful and feasible clinical tool in predicting readmission risk. Now, one of the things that they acknowledge is that it may be that it's kind of a catch-all for a lot of other risk factors. So they note that the people, the lower scores on the mini-cog tended to sort of capture a lot of other risk domains and disparities that we've already talked about. So lower performance was associated with lower socioeconomic status, education, minority status, female sex, depression, and higher comorbidity index. And what they said was that this is something that can be captured within 5 minutes. And if it's predictive, it's useful. Now, in addition, they note it may actually be a true mediator of outcomes, because what we could imagine in terms of things that determine whether or not a person is likely to get readmitted after a single admission for heart failure, if they also have dementia or they also have cognitive impairment, their ability to take their medications correctly, their ability to monitor their weight, which people with heart failure are supposed to do on a daily basis, and then adjust their fluid and sodium intake accordingly, their ability to follow instructions for diet and activity, and then their risk of having other events happen that are injuries from motor vehicle accidents or falls. So it may be that it's a true mediator of outcomes. It may be that it's a sort of catch-all risk marker. Now, looking at the other side of the street, how medical comorbidity affects cognitive health, again, the evidence is pretty clear that cognitive impairment has an excess prevalence in people with almost any other condition that that we can define. And certainly there's strong evidence for these that I'm showing here. Common conditions where it's clear that cognitive impairment and diagnoses of dementia are overrepresented in people that have these other diseases. This is just an example of a meta-analysis related to diabetes and the risk of dementia. And you can see here that the weight of the evidence for both vascular and non-vascular dementias is that people with diabetes are more likely to have or to develop dementias. And it's when we think about sort of our increasing understanding of dementia being a multi-hit disease, not a single pathology, but that in fact, that many other factors are impacting the structure of the aging brain that is affected with Alzheimer's disease neuropathology. And then additional factors affecting the symptomatology within dementia, or the function of that brain. These are just several examples here that we have the Alzheimer's pathology, but then in addition, we know multiple other hits, whether it's depression and anxiety, sensory loss, pain, medication exposures, and then microvascular disease are all affecting, in some cases, the structural and tissue level changes within the brain, and in some cases affecting the brain's ability to function and the symptoms that will manifest in Alzheimer's disease. This is from a review specifically about diabetes. All of the small circles represent a factor that is known to occur in diabetes. And the point that was made in this review is that all of these factors have an effect on the brain. So if we take just the example of diabetes, we can identify multiple things that we know are more common in people with diabetes or that occur as a result of the diabetes. And they all have a known or easily theorized impact on the brain. The other thing that is clear is that the sort of what I call the double whammy effect on multiple outcomes has been illustrated. So if you take cognitive impairment or dementia and add it to some other condition, there is generally a sort of double whammy effect, additive and sometimes more than additive on, for example, this is showing function. So this is some of my work using the EPI studies or the epidemiological studies in older populations, this one in North Carolina. And what we see is that as people's vision is worse, there's a higher prevalence of disability. As people's cognitive function is worse, there's a higher prevalence of disability. But for people who are in the far back corner that have both severe vision impairment and severe cognitive impairment, we're seeing 100% prevalence of having disability in at least one instrumental activity of daily living. In addition, there's this double whammy effect on function, regardless of what the comorbidities are. So just having an increasing number of comorbid conditions increases the chance of a person with or without dementia. So what you're seeing here is that those top lines, the really high steep lines, are showing the functional trajectories for people with dementia. So what you can see is that dementia has this kind of overwhelming effect on function. But within that, we can break it apart by are these people who are aging with dementia and 0, 1, or 2 or more additional chronic conditions. Then the lower lines are showing how the comorbidity, the burden of morbidity similarly stratifies these lines for people without dementia. So, so it is that dementia plus particular comorbidities sometimes has effects on function and outcomes that we can characterize really clearly. But what we also know is that even regardless of what the specific comorbid conditions are, just having an increasing morbidity burden along with the dementia affects trajectories of health. This is also not surprising, but there's also a double whammy effect on cost. So this is data from the UK, and this is showing the sort of excess cost associated with having dementia when you also have another condition. So this is saying in people with diabetes and people with urinary tract infections and in people with depression, again from UK data, the excess cost associated with those comorbidities in the presence of dementia. This is now data from the US showing a very similar trend. One thing that I think is interesting to point out here is that, again, dementia has a fairly overwhelming effect on cost. So the blue bars here are showing people who don't have dementia, and particularly in the low comorbidity groups. So in those that have an Elixhauser, which is a tool for quantifying or measuring the burden of morbidity, people with a low Elixhauser score, 0 or 1, those who don't have dementia have about half the cost of people who do have dementia and have a low Elixhauser score. But in each case, what we see is that an increasing morbidity burden is associated with greater cost. And then I want to sort of pause here and again state that this talk is about disparities related to comorbidities, but there's obviously disparities within disparities. So comorbidity rates, just like dementia rates, differ by race, sex, and economic status. And as we would expect, the people who are in the disadvantaged of those groups tend to have higher rates of all of these comorbidities, in addition to the higher rates of dementia. And so recognizing the sort of complicated nature of these relationships becomes really important. So circling back, that just, making that take home point that when we think about the disparities that are wrought because of comorbidities, it's important to realize the bidirectional nature of these relationships. So the problem then seems sort of simple in terms of, that to tease out these relationships, obviously what we need to do is to have data where the comorbidities are well characterized along with dementia relevant variables and outcomes. And we need databases that represent people with sort of an array of comorbidities in addition to their dementia diagnosis. The problem is that people with cognitive impairment and multimorbidity are extremely underrepresented in research. So it is true both that much of the extant data related to dementia that has really detailed granular information about people's dementia status sometimes lacks granular information about their comorbidities, particularly their affective health, depression and anxiety, and their sensory health, vision, hearing ability. And these being two domains of health and domains of comorbidities that we know impact dementia outcomes. So sometimes those domains of health are not well assessed in the databases. And then sometimes even when they are well assessed, the population in the study doesn't reflect the population of patients living with these complex arrays of dementia plus comorbidities. So the solutions to that are very complicated. I'll touch on a few of them, and in some cases it is just selecting, if we're going to try to address questions about comorbidity in dementia, selecting databases that do have decent granular information, or sometimes subsets of these populations. So for example, ancillary studies may have collected more detailed information about sensory health, and maybe better options than trying to address these questions about the comorbidity mediated disparities in larger databases that may have more measurement bias. So some of the tips for sort of leveraging the existing data. One thing to consider, particularly when using a data set that may not have great variables to characterize people's vision and hearing abilities, is that the cognitive tests may, to a more or less degree, have been affected by the person's visual or hearing ability. So for example, I'm showing here two examples of tests that are highly visually mediated. So your ability to draw a clock depends on your ability to see the paper. And your ability to complete this task switching test of trails making B, where you're connecting these dots and you're supposed to connect numbers to letters in order. So you may be slower on that test because you have a cognitive problem, or you may be slower on that test simply because you can't see the paper well enough to see the numbers and letters clearly. Now, when we try to get away from tests that require somebody to have good visual ability, we're forced into tests that require somebody to have good hearing ability. So sometimes thinking about how the tests themselves would have been impacted by these other domains of health is critical to sort of understanding just the measurement bias that we may be dealing with. second tip for sort of using the existing data to study comorbidity-based disparities in dementia is to use proxy data where available. So this helps with that issue of the inclusion bias for how difficult it is to participate in research for people who have cognitive impairment, for one thing, and particularly cognitive impairment with significant other morbidity burden that may also cause them to have mobility impairments or sensory impairments or other communication difficulties. So in that case, trying to use data sets that rely on proxy sources can reduce the underrepresentation of these groups. And then considering sensitivity analyses to sort of probe how the proxy obtained information could be impacting results. So then, and I think the talk that we just saw from Dr. Royal was a great example of how mediation analysis can really help to sort of disentangle some of the disparities that we see. And I think that using this approach to try to understand how comorbidities are impacting the outcomes that we see in our dementia work is very promising and becomes an essential way to sort of check ourselves and ask if an effect that we're observing that we're attributing to cognitive impairment and dementia may actually be partially mediated or moderated by comorbid conditions. Do we see this effect in dementia patients with diabetes, for example, the same way that we see this effect in dementia patients who don't have diabetes or who don't have depression? And I think as new treatments come out for dementia, it'll be particularly important to look at the moderation by comorbidity status. So again, trying to understand, is a treatment more or less effective in people who have dementia plus or minus some other. And then I'll touch just briefly, not on how we use the extant data, but how we potentially contribute to databases and an evidence base that is more representative. So I'll highlight here, and I think that there's some great work going on led by the CTSAs as well as the NIA related to trying to recruit more inclusive samples, particularly of older adults in research. So looking at inclusion across the lifespan. And I think that it's critically important here that we think about inclusion in terms of demographic factors, as well as these comorbidities that so often make it really difficult to participate in research studies if the studies are not designed with those comorbidities in mind. So I'm calling attention here to a paper led by a colleague of mine, Barrett Bowling, that takes kind of a framework called the 5 T's framework, that in the initial design, I mean, at the point of design study and importantly, budgeting for the study, considering factors that will increase the representation of people with comorbidities, which also has the effect of increasing other underrepresented or marginalized groups as well. And this just kind of drills down into some of the examples under each of what we call the 5 T's in specific ways that, for example, if people are required to come in for a certain set of studies, that considering that if people have high morbidity burden or perhaps vision impairment and cognitive impairment, that providing the option of door-to-door transportation through a car service might be the sort of thing that would really increase representation rates of this group. So I will stop there and take any questions.
Okay, thank you, Heather, for a very interesting and informative talk. First, I see we have a raised hand from the attendees. And I just wonder how it would work, because I think they can't speak. So
Maybe they can put
organizer,
it
can
in
you just...
chat.
So I see something in the chat. See a menu. Okay. I'm trying to let it happen, but it doesn't seem I can. So maybe maybe you can just type your question in the Q&A instead of raising your hands, if it would work for you. Okay, while we are waiting for this question to be typed, are there any other questions from the panelists?
Thank you very much. Yes, I cannot open my video again, but I use this opportunity to ask you a question. So very good presentation. My point, my question is that there is of course some connection between diabetes and Alzheimer disease or any kind of cognitive disorders. Oops. I'm sorry. Okay. And the point is that there is a glucose metabolism problem in the brain during neurodegeneration. Could you just clarify? Because until recently, the people recognize that there is some kind of different metabolic activity in the brain related to glucose metabolism, and the functions of insulin is different in the brain. And I think it's still, there are many open questions. I would like to ask you, could you just clarify a little bit more the situation?
Yeah, so I think diabetes is kind of a almost a perfect case of trying to look at the intersection of diabetes and dementia and how quickly things get very, very complicated, and trying to tease out all of the sort of bidirectionalness. Because the thing about diabetes is diabetes in and of itself is not a simple disease. It's not really first of all, there's grossly two different kinds of diabetes. So there are people who are resistant to insulin and people who don't make enough insulin. And so those two different kinds of diabetes could have different effects on the brain. But in particular, what we know is that not only are there metabolic changes in diabetes, and they're different in the brain because of the sort of different what parts of the sort of pituitary axis cross the blood-brain barrier, and also the brain's ability to utilize different molecules for energy than the peripheral body can use differ. So what we know is that the metabolic shifts that happen in diabetes and with treatment of diabetes. So people whose diabetes is treated with insulin, meaning that they have to give themselves exogenous shots of insulin, that impacts the brain differently metabolically. And so in addition to that, diabetes has all of these effects on the vasculature. So different from the effects on sort of energy utilization is the effects of what diabetes is doing to the microvasculature, which also has effects on the brain and the evolution of plaques and tangles and the kind of typical Alzheimer's disease pathology. So that's at least two ways. And I'm certainly not an expert in the molecular mechanisms of how a diabetic's aging brain with Alzheimer's disease is different than a non-diabetic person with an aging brain and Alzheimer's disease. But I think it's also important to note that in addition to that, people who are living with diabetes have all sorts of other ways. So for example, people with diabetes are more likely to have vision impairment because the diabetes affects the retina through the vascular changes. And what we know too is that having a lack of vision seems to affect at least the brain's function, if not the brain's structure. So that I've just sort of named three totally different ways that we think being a person with diabetes is impacting the brain.
Okay, thank you.
Okay, thank you, Heather. And let me go back to this raised hand from the audience. So, Pooja, you can go ahead and unmute yourself and speak.
Hi, I just have a basic question. Like, because we a lot of times see more diabetics, like African Americans have more vascular diseases and more diabetes. I'm more interested in the dietary pathways and how it can affect. So I'm looking at the data, which is a community-based data, and we have more diabetics in Blacks, but overall they're not eating that well. But the whites are eating pretty well who are diabetic. So do you think like there's also some other like mechanistic links that can be due to their other lifestyle behaviors, probably that can vary by race?
Yeah, so I think what you're touching on is maybe just some of this, what I call disparities within disparities that, you know, so you're sort of naming three different things. One is the comorbidity. So we do know that diabetes rates are higher in Black Americans and Hispanic Americans than white non-Hispanic Americans. Also, there could be geographic differences that even within kind of those groups, there are geographic differences in lifestyle factors that you're talking about, and sort of even whether people are urban or rural, or live in the Southeast that has sort of one diet than other parts of the US. And so I think your point is just well taken, that you know, I think that the as I said in the talk, the problem is sort of clear. The solution is a little bit trickier, because I think that to be able to try to tease out, and I don't think that we ever will entirely tease out, because these things are not only all true, but there's bidirectionality in all of them as well. So
yeah,
I don't know if
right. Yeah,
I think you're absolutely right.
Right. But again, controlling for vascular factors, when we're looking at race, like how much should be done, because then it can be like be a risk factor, but can also be a cause, as you stated before. But do you think when we are looking at race and dementia as an outcome, or cognitive decline as outcome, where should we place vascular factors? Should that be considered always as a mediator, or because
I think, yeah, no, I think it's important. I think we have to keep the comorbidity in some ways separate. You know, I worry sometimes that we place overemphasis on, when we observe race disparities in our data, that maybe we place overemphasis on wanting those to be entirely biologically mediated. And of course they're not. They're socioeconomically mediated, but also increasing recognition, I think, of the sort of issue of lived racism plays a role in development of disease, stress levels, and chronic inflammation. So I think that it's almost important to keep these buckets separate, rather than trying to tie up all of the race effect that we see with either vascular comorbidity or socioeconomic status, or a single genetic difference or genetic expression difference that we observe.
Okay, thank you so much. This is very helpful. Thanks for your talk.
Okay, thank you, Pooja, for very interesting questions. Okay, I see it's 11 a.m. right now, so I need to stop here. And thank you, Heather, for very interesting and informative talk.